Thank you, the organizers, DAISICON. I'm very happy to be here for two things. One is Dr. Amit Gupta from Lucknow is sharing with me. And another thing, the topics and the speakers, all three important topics. The first one is on premix insulin. Dr. Nallaperimal, please.
Good evening. Thanks for this wonderful opportunity. Now we are living the times where insulin companies are getting proud that they are becoming obesity marketing companies. So still insulin has not lost its charm. So it has got its own role. As we know, type 2 diabetes is a progressive disease. This is a sponsored talk. The presentation is made by Cipla. And we know type 2 diabetes is a progressive disease. It all starts as insulin resistance at the level of the muscle, liver and fat. And initially the compensatory hyperinsulinemia maintains the normoglycemia. Even though the process of developing type 2 diabetes has started by the way of background insulin resistance, but the person has got normal blood glucose level. Then it moves on to pre-diabetes stage, then to overt diabetes. Then the control gets worsened as years go by, and the patient requires more and more drugs to control. As this goes on, the number of functioning beta cells also goes down. And at some point, the patient starts having microvascular and macrovascular complication and requires further intensive insulin regimen. So in this context, we need to understand the insulin initiation and intensification, especially in a disease like type 2 diabetes where it is progressive. So there are a lot of selection factors for insulin regimen. Whenever we want to start insulin, first we need to look into the age criteria. So whether the person is young, old, and whether there is an increased risk of hypoglycemia because of the background issues, and the clinical profile of the patient, whether the patient has got a cardiac illness or chronic kidney disease or frailty, so which might lead to hypoglycemia and other problems. And then we have to look into the cost and patient preference also, because we have got a bouquet of insulin available starting from human insulin to analog co-formulations. The cost varies widely. So we have to have a discussion with the patient about their preference and affordability. And finally, look at the patient's glucose pattern. So whether the fasting is under control or reasonable, or it is a postprandial glucose which needs to address first. So all that need to be taken into consideration before we prescribe insulin. So, and we have three basic options. Whenever the fasting glucose is very high, when the patient presents with high fasting glucose, obviously a basal insulin alone may be sufficient on top of the background OADs. And if the fasting and postprandial glucose need to be addressed together, then premix insulin will be a better choice. And when the patient also prefers a less complex regimen, because the patient can progress from one pen to the same pen for the second dose, premix can be preferred. Basal bolus insulin regimen is more intensive and it has got its own place whenever you need to control both the fasting and postprandial glucose, as well as when the patient is in the hospital. In the hospital setting, we don't use premix insulin. We always go for a basal bolus regimen. And whenever a young woman who wants to conceive has got type 2 diabetes, of course, we need to go for basal bolus regimen. So these are the situations where intensive insulin therapy is preferred. And once we decide on insulin, prescribe insulin, then we have to decide at what frequency we are going to titrate the dose, because that need to be discussed with the patient. If you are going to empower the patient to have a glucometer and self-monitoring is going to be done, then discuss with the patient whether it's once weekly or twice a week, depending on the levels. And then have a discussion with the person about the target glucose level, what we are trying to achieve, because the patient need to know what we are trying to achieve. So the general level which are acceptable for most patients will be around 80 to 130 preprandial and 180 less than 180 postprandial. If that is the level which the patient could achieve with insulin, then the control is good. And the titration order, if the fasting plasma glucose is very high, then you address that first. if suppose a patient presents with fasting and postprandial high glucose levels, try to fix the fasting first. Then once the fasting gets stabilized, then start addressing the major meal which requires attention. So why intensification is needed? Obviously, we need to achieve the target HbA1c because we need to individualize the HbA1c target to prevent future complications. And fasting and postprandial, both glucose levels should be controlled. And we are looking at prevention of long-term complications and maintaining the quality of life. So we have to avoid clinical inertia whenever intensification is required, and it needs to be individualized. And this is the RSSDA guidelines. Whenever a patient is already on basal insulin, then you have various choices. Basal insulin still not under control, then you have the option of switching to premix insulin twice daily. It could be a human premix or analog premix, or you can switch to co-formulation, or you can add a prandial insulin wherever the glucose level is spiking, or if the patient can afford, then you can go for GLP-1 analog. And clinical inertia in insulin initiation and intensification is a big problem. It is defined as the failure to initiate or intensify insulin therapy despite uncontrolled hyperglycemia. Because we all have our own challenges, busy OPD, patient is resisting mentally, and then we just sign off the prescription without convincing the patient to go for insulin. So provider related delays is about 50%. So we are doing the mistake of not convincing the patient, not spending enough time. That is about 50%. And patient hesitation is about 30%. And healthcare system barriers. Suppose you prescribe insulin, the pen is not available, or diabetes educator is not there. Nobody is there to teach the patient how to inject insulin. All that is system barriers. And we have to surmount all these barriers. And the fact is, in India, the median time to intensification exceeds almost 7 years. That means 7 years of uncontrolled hyperglycemia is documented before the patient gets insulin. And there are various patient factors also. So age could be a factor, lifestyle, dietary pattern, type of diabetes, clinical features, risk of hypoglycemia, weight gain, personal choice, cost, all these could be personal patient factors. And system related factors is limited access to education, because most of the clinics won't have a dedicated diabetes educator, and the physicians are already overburdened with a heavy OPD, and limited training of providers in injection techniques as well as poor adherence. All these factors contribute to delayed intensification. And how we are going to overcome the intensification barriers? We can simplify and personalize the regimen. So if you are going to prescribe something very complex for the patient to understand, then it's very difficult for them to follow. So you can prescribe something very simple, say for example, premix insulin once and then progress to twice. That improves the patient adherence and confidence, and it can address the other, both the clinician and patient related barriers. And we should never forget, even after prescribing insulin, the patient requires continued education and motivation. So we have to educate the patient at initiation, titration, as well as intensification phase. And timely initiation and intensification is very, very important, and it need to be supported. Maybe there are now WhatsApp facility available. Clinic staff can call them after 4 or 5 days, how they are doing. All that need to be done. And we have to empower patients to achieve long-term success. So coming to premix insulin, their role in the management of diabetes, choosing a premix insulin allows you to both cover both the fasting as well as postprandial plasma glucose. It allows for gradual intensification from once daily premix to twice daily and even thrice daily. And dose adjustment can be personalized based on glucose monitoring values. So of course we need to empower the patient to have a glucometer, do self-monitoring at regular intervals, and teach them how to adjust their own doses, or you can always dedicate one of your staff to discuss with them about the adjustment of dose. So it simplifies the regimen for patients needing structured but less complex insulin strategies. So when we are going to titrate the dose whenever the HbA1c remains above target after initiating. Now, the patient is on insulin, but stays on the same 10 units what we started for months together. So, obviously, you have to look at the HbA1c and then keep titrating the dose. And if the fasting plasma glucose remains above 130 milligrams per deciliter or postprandial above 180, despite the current regimen, definitely this regimen needs to be intensified. Or the patient brings in SMBG logs and it shows lot of variability, obviously you have to address that. Or after initiating once or twice daily premix insulin, we have to monitor the pre-breakfast and pre-dinner values to decide about further intensification. So, these are the ways of stepwise approach to titration based on fasting and plasma glucose levels, postprandial glucose levels. So, you have once daily premix regimen. So, once you start before breakfast, obviously you have to look at the pre-dinner value to adjust the morning dose. And if you are using a twice daily regimen, you will be looking at the pre-dinner value to adjust the morning dose, next day's fasting to adjust the dinner time dose. And TAD regimen, of course, the lunchtime dose is given, so you will be looking at the pre-dinner value to adjust the dose. So, minimum once weekly monitoring is required, because remember, suppose if you have started the insulin for the first time, the patient is insulin naive. So, minimum once or twice weekly they have to monitor, and we have to use the lowest or mean of the last 3 values for dose adjustments. The patient brings in 3 values, you can take either an average or the lowest value as a guide. And in case of hypoglycemia, any blood glucose level less than 70 is defined as hypoglycemia. If hypoglycemia occurs, rule out the cause first. If the patient has missed a meal, missed a snack, or delayed the next meal, it's a patient problem. Then you have to re-educate them. If there is no identifiable cause, reduce the current insulin dose by 20%. And in patients who are having repeated hypoglycemic episodes, it is better to switch over to analog insulins. So, we will look into 2 case studies. This case 1, 58 years, type 2 diabetes, 6 years duration, HbA1c 8%, BMI 27.5, started on Lispro mix 25 BID. Initial dose was 12 units in the morning, 8 units before dinner, and the target set was 80 to 130 milligrams. Then monitoring, the patient was advised to check the fasting as well as pre-dinner values. And you can see the table. So, slowly the blood glucose levels start coming down. So, fasting was 162 and then pre-lunch was 180. Then the morning dose was increased by 4 units, evening dose also was increased by 4 units. Then you can see the improvement in the fasting as well as postprandial pre-lunch glucose, and the patient ended up at 18 units morning, 12 units pre-dinner to achieve this level of fasting 108 and 124. So, HbA1c reduced by 7.2% at the end of 8 weeks. Weekly titration was based on 3-day average of pre-breakfast and pre-dinner values, and simple 2-point monitoring schedule spread over 3 days a week. It's very easy for the patient to follow. And intensification, obviously, when we have to intensify beyond titration, whenever the glycemic targets are still not met despite regular titration, or HbA1c is not at target even after 3 months of starting insulin, persistent pre-meal glucose levels are above target, or then in such situations you have to consider intensifying these patients twice daily insulin regimen to thrice daily insulin regimen. So, this is one such scenario where step 1, you are starting with once daily premix insulin, then intensifying twice daily, and then finally adding the 3rd dose, that is pre-lunch dose of a premix insulin. Generally, the pre-lunch dose, if you are going to add, the patient will require very small dose only. So, for example, morning 18, night 12 is the usual dose. Still, you want to add a pre-lunch, it will be around 4 or 5 units only. And generally 50-50 mix is preferred when we go for the TID dose. This is again another case, type 2 diabetes 10 years, long duration, already on metformin, sulfonylurea and human mix 30-70 twice daily, 12 units and 8 units morning and evening, has a fixed lifestyle but sedentary, HbA1c 9.2, fasting plasma glucose 190, post lunch 250, pre-dinner 200. So despite being on sulfonylurea, metformin as well as premix insulin twice daily, still the control is not good. So let us see some evidence. This is one such study which enrolled 40 type 2 patients who were on premix 3070 human premix insulin. So these subjects were enrolled and they were enrolled into the study, and they underwent a crossover design. So that means they were continued on 3070 insulin for 3 months, and then they were crossed over to 50 premix analog insulin thrice daily. So twice daily versus thrice daily. And if you look at the control, the HbA1c level and plasma blood glucose level control, that was better for Lyspromix 50 TID. But this is no brainer. Someone who is on twice daily premix 3070 getting converted to thrice premix 50 thrice daily definitely will have better control. The issue is like whether they had hypoglycemia, whether the control was achieved safely, and whether the convenience was there. All that was looked into the study, and they found that Lyspromix 50 3 times was better than the premix twice daily human insulin. So back to case. So this patient was started on Lyspromix 50, and you can see on the right side 16 units before breakfast and 10 units before dinner, which was later titrated to 20 and 12 depending on the fasting, pre-lunch and pre-dinner value. Again, since the control was not good, they introduced a third dose of Lyspromix 50 for the lunch. Look at the dose. They continued this morning dose 16 and 14 for the dinner, but small dose of 4 units was introduced for the lunch, and then that improved the control. So the HbA1c also improved to 7.1. So the outcome was smooth transition to TID regimen using 50-50 premix analog insulin. All pre-glucose levels were within the target of 80-130, which was set after discussing with the patient, and HbA1c got reduced to 7.1%, and the overall control also improved. So the role of premix Lyspro in intensification is very easy. Like Lyspromix 25, you have 2 compositions available, 25 premix as well as 50 premix. So 25% rapid acting insulin Lyspro plus 75% proterminated Lyspro, that is Lyspro is LM25. It targets postprandial glucose after breakfast and dinner. So suppose if your patient requires good control after breakfast and dinner, you can start this. And if your patient is a high carb eater, then you go for the 50-50 Lyspromix. So that is better for controlling postprandial glucose after carbohydrate heavy meals. So addressing patient concerns, meal consistency should be emphasized. Whenever you start a premix insulin, obviously it's a fixed composition. The patient need to take the mid-morning snack, should not delay the next meal, and need to take the mid-evening snack and should not delay the dinner. If they are going to do that, then they can end up with hypoglycemia. So the meal time should be reasonably accurate, and we have to educate on recognizing symptoms of hypoglycemia and using rapid carbohydrates. So whenever a patient is getting started on insulin, the discussion about hypoglycemia should be undertaken. And insulin injection technique should be taught perfectly, because they have to rotate the insulin injection sites, and timing of the doses with meals also need to be discussed. So finally, to conclude, type 2 diabetes is a progressive disease which leads to declining beta cell function. Over time, many patients will require insulin therapy and subsequently its intensification to maintain glycemic control. Premix insulin, especially in a country like India where we have patients who continue to eat carbohydrates, high carb meals, despite dietitian's advice, premix insulin offers the advantage of addressing both fasting and postprandial glucose in a simplified and single injection format. And structured education, supportive counseling, and use of SMBG or CGM can help to mitigate the barriers of clinical inertia. And it is time to shift from a wait and watch mindset, because whenever patient comes with uncontrolled diabetes and tries to buy time from us during every clinical encounter, instead of accepting to their whims and fancies, it's better to try to convince them to go for insulin. So we have to turn our mindset to a treat and tighten strategy to ensure patients to receive timely and individualized care for optimal outcomes. Thanks for your patient listening.
Thank you, doctor. Thank you very much. Almost you have covered all the practical aspects of insulin, not only premise. Thank you. We'll have questions at the end. The next speaker.
So the next speaker is Dr. G. Vijay Kumar, and he's going to talk on can SGLT2 inhibitor be the foundation of the early diabetes care. Dr. G. Vijay Kumar, I don't think need any introduction in this part of the world, and he is the organizing chairman of the RSSDA 2022 National Conference, which we all witnessed as a grand success. So over to you, sir.
Good afternoon. I'm really happy to be here. For one reason, I think I still remember me, I was the treasurer and Dr. Panneerselvam used to be the secretary. We used to have almost every monthly meeting in the afternoon, but now it has gone to a different level. So Shanmugam and others, Dr. Anand Mosan are taken to a different, Periandavar is here. So that is one reason. And the other second reason I'm very happy is that our dear chairpersons, both of them are wonderful human beings. I always say that. Madam Bharani, Go Bharani, who is my senior actually, and Amit, my good friend and like a brother to me, younger brother, great human being as well. So thank you for being the chairing for my session as well. Now, today I'm going to speak about what type of a decision you need to take clinically. Basically, when you clinical decision, especially dapagliflozin, SGLT inhibitors in general, and then also regarding dapagliflozin use, and two issues. Can we use it in type 2 diabetes from the beginning? That's a big question. I think we all agree that it's a very good molecule to use from the beginning itself. Why should we not use it unless there's a contraindication? Number two is that how is it can be useful for multiple risk factors which are usually happening in our practice. So type 2 diabetes is not just only blood hyperglycemia. It is basically the insulin resistance syndrome associated with hypertension, obesity, and dyslipidemia as well. So multiple risk factors are common in most of our patients, and I think how is it can be SGLT inhibitors such as dapagliflozin can be useful to us. I would like to say that this is a sponsored program by AstraZeneca. Now let me go with probably a typical case that we generally see in our practice. Here is a patient who has got type 2 diabetes for 6 months. His HbA1c is 7.8 in spite of having metformin twice a day for 500 milligrams. In spite of having telmisartan, blood pressure for 1 year, and it is still wanting 140 over 90. And you can see that dyslipidemia, generally you can see that last 8 months and is on rosuvastatin. And then you can see that LDLC is 121, HDLC is 55, and triglyceride is 158. This is very typical of Indian phenotype. What is missing is that HDLC is never 55 and high in our usual practice. Actually, you can see that. So there is a caveat here actually. Usually we'll have a low HDL and not very big LDL. Triglyceride is slightly elevated to that. And BMI is as usual. You can see that this patient has got a BMI of 30. And CKD parameters such as eGFR and urine albumin creatinine ratio is not available here. Now, why is it we need to look into these two aspects? That is why is it important for us to calculate eGFR and also urine albumin creatinine ratio? The reason is that if you look into that, the diabetes is the single most significant cause of CKD, followed by hypertension and glomerulonephritis, 18 and 18, but diabetes contributes 42%. It's almost 2.5 times that of other causes can cause CKD amongst people. And then it is 42%. And recent side study what we have done published about 6 months ago, showed that in India we have about 32% of the people who have got CKD in diabetic patients. Now, why is it important? If you look into that, you just look into this, a very nice slide where you could see that, within 12 years of occurrence, compared to glomerulonephritis, they go into end-stage kidney disease within 12 years, almost 4.5 times. It is more than even hypertensive CKD. So definitely you could see that compared to glomerulonephritis and hypertensive CKD, diabetes CKD is going to be a more progressive disease compared to other conditions. Now, the problem also is that it is underdiagnosed. One of the things is that basically CKD in the early stages is asymptomatic. That is number one. Number two is that awareness amongst the patients. And usually albumin creatinine ratio is usually not done on a routine basis. This is the only thing. And that is the reason only 5% of the adults with CKD are diagnosed. Then you might ask me, why, how can it be 32%? We looked into that. We investigated. And then we found that 32% of in our country are having CKD. But whereas if you look into the dyslipidemia, we regularly do dyslipidemia and also blood sugar control, but we don't do it that much, the albumin creatinine ratio, to find out how many people are having CKD. Only 5% are diagnosed. And also, it is very, very important, once you know that, whether you have CKD or not, it is always very essential to look into the KDICO guideline, where we need to classify the stage of the disease, which is very, very important. The reason is very simple way of looking into that. Look at the left side of your screen. You could see that according to the albuminuria, you can have A1, 2, 3. You can see that when it is albumin excretion is less than 30, you can see in green, you can see that this is A1. And then from microalbuminuria is considered as A2, and macroalbuminuria, when it is more than 300, it is considered A3. And look at the eGFR. You can see that more than 90, 60 to 90, 45 to 59, and 30 to 44, and goes on. Now, why is it very important to look into eGFR also? Is that quite a good number of people in diabetes have got no albuminuria, but can have a reduced eGFR. So there are two aspects that you need to see that. You may have a good albuminuria, but normal eGFR. Similarly, you can see that no albuminuria, but still you can have reduced eGFR. So this is what, but that is the reason we need to classify the stage of this the disease, so that the strategies to counter the issue, especially glycemic control, hypertension control, and the drugs that we need to give, selection of the drugs that we need to give is very, very important when you know the staging of the disease. The strategies are going to be different with each stage. Now, this person we have calculated, and then we found eGFR is 75, that is not normal, that is 75, and you can see that albuminuria is normal, less than 30, there is nothing. Now, at this stage, this person will go into what is called as A1 and G2, because you can see that the eGFR is between 60 to 90 and less than 90 actually, and then there is no albumin, but still in a green zone. That means it's in a safe zone, but we need to look into many things. Now, for example, here if you can see that, in the same stage, if the patient has got also hypertension and dyslipidemia, the situation is going to be different. Situation is entirely different. So you need to have a better strategy and more strict control of everything that should be done. Now, what is happening is that if you can see that, the reason why we need, even if it's a green zone, still we need to have a different strategy, because type 2 diabetes initiates a cascade of heart and kidney damage. You could see that. If you have a CKD and heart failure are the earliest and most common CV complication type 2 diabetes. Now you might be wondering why CKD is considered as a CV complication. I'll come back to that in the next slide. Now the third thing is that 40% of the people living with type 2 diabetes develop CKD, and in India it is 32%. I mean, that's one study, but it can be quoted as that. Now, Why is it we need to know? Again, one more reason why we need to know about the staging of the disease is that glycemic control. Once upon a time, we used to say that, about 25 years ago, when a teaching is that we have somebody has got a CKD. What is it you do? Good glycemic control, good hypertension control, nothing else. Okay? Then, now you would have also known about the statin therapy and have a residual risk. Similarly, you can see that even in diabetes, for CKD, you have a residual risk in spite of having a good ABC control, that is A1C, blood pressure and cholesterol control. This is from STENO2 trial, which is one of the most wonderful trials we can think about. My most favorite trial actually. It's a very small number, 70 plus 70, but a wonderful trial. And then you can see that the residual risk still is about 25% in spite of a very good control. So what does it indicate? We need to do something extra. It's not just comprehensive control, but also you need to do something extra, that is SGLT inhibitors. Now, another thing is that look at the heart failure. Look at the heart failure. You could see that all the studies, that landmark studies such as UKPDS, let us not talk about UKPDS. You look at the ACCORD trial, advanced trial, VADT trial. ACCORD trial, there is a more hospitalization for heart failure, whereas there is no advantage of good glycemic control as far as the heart failure is concerned in advanced and VADT. Now, why ACCORD has got more ring? Because one of the reasons is rosiglitazone was there in 65% of the patients, and if you look at all the three trials, ACCORD, advanced and VADT trial, everybody has got a multiple risk factors, and 40% of them have got established cardiovascular disease as well. This is a different state. But one thing is that all these three trials have ensured that a glycemic control and everything is normal, but still there is admission for heart failure, like what we have seen, residual CKD risk. Now, why this happens is that you can think about what is called as common soil hypothesis. You can see the RAS activation, neurohormonal activation, inflammation, endothelial dysfunction, ischemia, fibrosis, oxidative stress, which are common for both heart and as well as the kidney, and it is one CKD increases the heart failure. If you have a heart failure, it increases the CKD also. So it's interlinked. So this is one thing what we need. So both to be addressed so that we can get a good, happy life. Now, if in this situation, what is it we need to our patient, for this particular patient or any patient, what we think about is a good glycemic control, number one. Risk of heart failure events has to be reduced, and then we need to address also the occurrence and progression of nephropathy as well. So more of prevention. So prevention is better than treatment. Usually say cure, but it's no cure here, but at least that. Now, if suppose SGLT inhibitors such as dapagliflozin, why should we start early in type 2 diabetics? Is one thing is that this is a very, very effective, as an effective anti-diabetic drug. Friends, let me tell you about long ago when we had that, the EMPIRIC outcome and, also the dapagliflozin studies have come, declare to me, what you call declare to me. They have started as a good anti-diabetic drugs, and only later on we found other pleiotropic benefits. So it's a good glycemic control. You can see that it can be added on to any other, including insulin, metformin, and to SGLT inhibitor, you could see that a very good reduction in HbA1c. And then reduction in HbA1c is not the only thing what we need to look into, that durability. You could see that even at the end of 4 years, you could see that dapagliflozin is able to sustain the good glycemic control compared to placebo. Now, declare to me the trial, which is the first RCT, like the three molecules that we had, that is canagliflozin, dapagliflozin, and empagliflozin. The dapagliflozin was instituted in the RCT, that is called as declare to me 58. What they have found is that there is close to 30% risk reduction for hospitalization due to heart failure. This is a class effect which is there in the molecules. And most important thing is that 40% risk reduction for renal composite endpoint, that is the more than 40% reduction in eGFR and ESKD and renal death. which is also possible as a primary prevention in this particular molecule. We'll look into that as well. Now, in the same declare-TIMI trial, what they have found is that different categories of albuminuria, that is from micro to normal, and macro to normal or microalbumin, and macro to normal, macro to micro, any stage you could see that it favors dapagliflozin, where it is able to reduce the disease progression, and rather it can, at an early stage, if we can do that, we can even revert back the progression. We are in a very good stage. Now then came this one more interesting study, real world evidence study called Darwin Real, where they have found is that those people who had a dapagliflozin, the EGFR reduction is very slow compared to those strategies of treatment where there was no SGLT inhibitor at all. So you could see that there is a difference in the pink and the dark line, you could see that. And then the same, one more product that has been very good for renal protection and cardiovascular protection is GLP-1 receptor analogs like SGLT inhibitor. Even comparing to GLP-1 receptor analog, dapagliflozin has shown a very good impact in not reducing the EGFR compared to even. And then one more thing has happened in this real world evidence of Darwin renal study is that the new onset of CKD is reduced compared to other strategies of treatment therapies. So you can see that the progression is retarded, and also new onset CKD also is reduced. What else you want? This is what we need to look into that. No doubt with all these, with all the evidences that you have, you can see that when you have a CKD or ASCVD, you can see that the drugs of choice are GLP-1 receptor analogs and as well as SGLT inhibitors. You could see that. And also it also says that those people who may not have CKD, but those people who got indicators of high CVD risk also are the right people to get into drugs like dapagliflozin. Like you can see that indicators of high CVD risk include age more than 55 and plus two more additional risk factors such as obesity, hypertension, smoking, dyslipidemia or albuminuria. You could see that. So you can see that. And again, the goal for achievement of maintenance of weight and glycemic goals, you should have a powerful molecule to improve the glycemic control. At the same time, no weight gain, rather weight reduction, and that is possible because we could see that achievement of maintenance of weight and glycemic goals can be, you can see that in the down there, the powerful glycemic reduction, that is HbA1c reduction, is possible with GLP-1 receptor analogs, metformin, pioglitazone, SGLT inhibitors, and sulfonylureas, with a pleiotropic benefit that we need to understand with this molecule. So now compare to which one to use DPP-4 inhibitor, or you want to select SGLT inhibitor. But nowadays we are using all the three molecules, that is the anti-hyperglycemic drugs. Friends, you should differentiate between a hypoglycemic drug and anti-hyperglycemic drug. Hypoglycemic drugs are sulfonylureas and insulin, which can cause hypoglycemia. When you use DPP-4 inhibitor, SGLT inhibitors, metformin, they are anti-hyperglycemic drugs, very unlikely to develop hypoglycemia. Now let us look into the comparing DPP-4 inhibitor with dapagliflozin. HbA1c reduction is superior compared to DPP-4. BP reduction is available, which is a very good sign, which is not possible with DPP-4 inhibitor. Weight reduction, DPP-4 neutral, there is a weight reduction of minimum of 3 to 4 kilos. And then you can see that primary prevention, heart failure, 36% risk reduction, it is a classified again. A renal, 49% risk reduction at the renal endpoints is possible, which is not available with DPP-4 inhibitors. They are weight neutral. There is a warning because of saxagliptin, but not with sitagliptin or dapagliflozin. Vildagliptin. And then you can see that ADA is recommended in high-risk type 2 diabetes first-line treatment. The high risk means almost every patient is a high risk, right? There is no mild pregnancy or severe pregnancy. Similarly, there is no mild diabetes or severe diabetes. So I think every patient, unless it's contraindicated, you should have glucose layer which is very, very high compared to DPP-4 inhibitor. So what else you want to think about SGLT inhibitors such as dapagliflozin for your use. Now, you comparing the declare TIMI with EMPERAG, it is not fair enough for us to compare two studies, because the population, the subject population in the trials is entirely different compared to these things. But nevertheless, what is most important is in the declare TIMI, there is, you can see that there are the normal people without complications also are possible in declare TIMI, and that is the reason even without CKD we can have, without CVD also we can have, but as EMPERAG outcome has shown everybody, almost 100% of them have got cardiovascular disease at that. Now we have a lot of generics, and then we can see that the difference between a generic dapagliflozin and the innovator dapagliflozin is that you can see that it's a crystalline, innovator is a crystalline that named as Foxica, and then generic dapagliflozin is either crystalline or amorphous. Molecular weight is, there is a difference between 502 versus 408, and then more trials with innovator, we all of us know that. But what you can see that this is a paper published during Diabetes India at Goa about 2 years ago by Kalra, Sanjay Kalra et al. What they have found is that the reduction in HbA1c is better with innovator 1.26 versus 0.76, and nocturia, very important thing, is only 20% compared to 70% of the generic. This is from, the data is from a poster presentation by Sanjay Kalra and group that has been presented at Goa Diabetes India 2 years ago. Now you can see that here is that in this particular patient, type 2 diabetes, still wanting, add a dapagliflozin so that you can get a better control, BP reduction can be possible. Look at this dyslipidemia, which is not right here actually, but the particular Indian phenotype of dyslipidemia, where there is lower HDL and more triglyceride, these things can be independently, you can get the benefit when you use SGLT inhibitor. And he has got a 30, that is BMI is very, very high, very good, weight reduction is a possibility. And also you can see that to mitigate the progression of the disease also, this is a possibility. So friends, let me conclude to say that type 2 diabetic patients are at risk of developing CKD and heart failure as well. Glucose control alone may not be sufficient. How you bring down the blood glucose is not the one. And bringing down the blood glucose is not important. How you bring down the blood glucose is very, very important, where the right molecules are a choice of molecules that should be there so that you can prevent the complications such as CKD and heart failure. And then guidelines like ADA has also shown that this should be a primary. And in fact, we have a lot of, in one of the articles, I am also an author in that one of the review article, where we have clearly said that it should be a primary drug along with metformin, unless it's contraindicated. And this is what we have been practicing all through. And one more thing is that Indian phenotype, BMI may not be very, very high, but you got a waist circumference, ectopic fat. SGLT inhibitors will reduce ectopic fat. It reduces the waist circumference. So it's, so many things are there with the SGLT inhibitor. And declare TIMI has shown Darwin real, that is the real world study has shown that there is a very great improvement with dapagliflozin. And also we know that several studies have created that SGLT inhibitors will reduce the heart hospitalization for heart failure, and also renal parameters also will improve. And then, so don't hesitate to start SGLT inhibitors as a primary drug along with metformin in all newly detected diabetics, or even in the patient comes first to you. Thank you for your patient hearing.
Thank you, Doctor. SGLT2, when it was introduced, we were very happy to see the diabetic benefit. But later we were wondering, does our diabetic patients have so much heart failure? But seeing the effect on heart, we understood heart failure better. Then when we don't have anything much to do, when the patient has renal compromise, there is a drug to, we can do something, some consolation. Now there is a third speaker, Dr. Thirumal Valavan, to talk on the proteinuria on diabetic patients. Proteinuria worsens kidney disease worsens proteinuria. We need better drugs to treat proteinuria. Please, sir.
Good evening all. I first thank the organizers for giving this opportunity to me. I am working as assistant professor in Stanley Medical College. And my 50% of the topic was covered by my previous speaker excellently. So I will have less to talk regarding this proteinuria. So here we are, look, if my topic is carefully seen, it is adjuvant therapy to reduce proteinuria. We all know the standard pillar of therapy, so I will be talking more on the adjuvants that we have to decrease proteinuria. All we know is CKD is a irreversible disease, which is a progressive renal damage, and traditionally we have been classifying CKD based on 5 stages, only looking at the eGFR, and creatinine was the measure used to decrease this. As we know, even when the GFR is more than 90 with respect to diabetes, he becomes stage 1 CKD, and the stage 5 is GFR less than 15 ml per minute, which we also called as end-stage renal disease. And then in 2012, KDIGO, which stands for Kidney Disease Improving Global Outcome, came out with this heat map. Traditionally, as I said, we have been looking into only GFR, and in 2012 they incorporated the albuminuria into the CKD classification. So this was in 2012. This was already described how a patient with the higher GFR, that is, even he may be having a GFR more than 90, but if he is going to have a higher degree of proteinuria, he will still be falling under higher risk. And A1, A2, A3 has been clearly explained. A1 is even a patient who doesn't have albuminuria. So normal or mildly increased, which is less than 30 milligram per gram of creatinine. And A2 is moderately increased, and A3 is severely increased. This micro and macro have been replaced by moderately increased and severely increased proteinuria. And why we need to look into this albuminuria is, this is definitely an indicator of the endothelial damage that is occurring in all through the blood vessels, more so in the kidney. And this is again 2024, the same heat map. What I want to emphasize is, even after a decade, there was no absolute change in any of the albuminuria creatinine classification. And now if I am going to write a patient as CKD, I need to put them into 3 classifications. That is, I need to classify what is the cause for a CKD. That stands for C. G is for GFR categorization based on the creatinine. And 2024 says we can take creatinine or cystatin and combine creatinine and cystatin also to classify the GFR. And third is albuminuria. So only if I want to say, now I have to write them as CGA classification. Probably this would be the cause, and GFR categorization along with A1, A2, A3. This would be my complete diagnosis of CKD. Then all we know this, why this albuminuria occurs is because there is some defect in the GBM, that is filtration barrier, which is constituted by the endothelial cells on the vascular side and globular basement membrane, and on the other side it is by the visceral process of the food process of the podocytes. So whenever there is a defect in charge and select barrier in this, we are going to have a leaky GBM, which results in proteinuria. And in the context of diabetes at least, basically there should be an intraglomerular hypertension, and this hypertension causes damage to the endothelial cells, which results in leaky glomerulus manifesting as proteinuria. So this intraglomerular hypertension can be because of increase in the efferent arteriolar tone, which can be mediated by angiotensin II, endothelin 1 and reactive oxygen species. Or this can be because of a afferent arterial vasodilatation. This is the decrease in the afferent arteriolar tone, which can be again mediated by several players, one being the nitric oxide, and also predominantly in the setting of diabetes, especially the SGLT2 mechanism works by modulating this tubuloglomerular feedback. And what does this KDIGO say regarding evaluation of albuminuria? So initial testing of albuminuria is very vital, because this is what is going to tell you about the renal damage that is occurring. In all cases, a first void morning midstream urine is most important, and the algorithm to go about is always go for urine ACR, that is albumin creatinine ratio, and when that is not possible, we have to go for a dipstick analysis for albumin analysis. And if only protein is available, next would be to look for urine protein creatinine ratio, and again the dipstick analysis for looking for protein. And always confirm the semi-quantitative measures by doing a quantitative laboratory measures. That is, you quantify comparing with the creatinine, albumin creatinine ratio or protein to the creatinine ratio. And if you have done it in any random sample, it is better to confirm it, reconfirm it with the early morning sample to look for this ACR. However, this ACR, PCR also, there are some certain caveats, and we need to look into where there can be situations like there can be a falsely elevated ACR, in the setting of hematuria following an exercise, any infection or non-albuminic proteins can also be shown as elevated ACR. Similarly, there can be situations where you can get a decrease in PCR. As you know, males usually have higher body mass and hence their creatinine will be higher. So when you are looking into the ratio, it may give a falsely low. So these also should be looked upon while interpreting ACR or protein creatinine ratio. So these are the various pathological changes, especially in the context of diabetes, which occurs. For want of time, I am skipping this. And this is a better classification that is always discussed in any rounds about the various changes that occur in a patient with a diabetic nephropathy. So first it goes through a stage of hyperfiltration, wherein you usually have a higher GFR. If you do a creatinine, it may be 0.9 or 0.8, and GFR will be much more. This is the stage of hyperfiltration. Then it goes to a stage of silent nephropathy, where there will be mild GBM thickening, but here you are not going to have any you are not going to have any protein leak. The GFR also would be normal. Then comes the stage of incipient nephropathy, where there will be GBM thickening, and clinically you may appreciate a moderately increased albuminuria. Then comes the stage of overt nephropathy, where there will be a marked GBM thickening with various mesangial changes also occurring. Here definitely the patient would have a decreased GFR along with the increased albumin excretion. Then comes the ESRD, which is the end-stage renal disease. So if we look into the landscape of therapeutics of CKD, we can divide it into 4 eras. This is how it is like CKD therapy. Now it has shifted from a therapy where we have been relying only on single drug, where we have been relying only on ACRB. Now we are moved on to a multi-drug era, utilizing RAS inhibitors, SGLT2 inhibitors, MRAs, and also added to the GLP-1 RAs. The strategy is no longer just for diabetic kidney disease, but it applies to all forms of CKD. And by 2025 plus, CKD care looks more like a heart failure care, where we are going to have guideline-directed medical therapy involving the all available agents. So I can put it like the foundation era. This would be around 1990 to 2005, where we had no other choice except RAS blockade. And the famous trial like Captopril, IDNT, Renal, IRMA, Microhope, any number of trials have shown the benefits of utilizing RAS inhibitor in diabetic as well as non-diabetic kidney disease. For almost 20 years, RAS blockade was the only proven therapy for mitigating CKD progression. Then comes this stagnation phase, where we did not have much progress. So in this year between 2005 to 2014, there have been no major breakthroughs, nor any new drug that have been discovered. Then came the breakthrough era, where we had this SGLT2 inhibitors, that is between 2015 to 2022. This expanded the benefit to non-diabetic. Taking clue from the Credence trial, then came the DAPA CKD and also the EMPA-REG trial. They went on decreasing the GFR, and in the EMPA kidney, they showed that it is beneficial even up to GFR of 20 ml per minute. Then come this NSMRAs, this Figaro DKD, which showed the utility of finerenone and added renal and cardiovascular benefits on top of ACARB inhibitors. And this SONA trial in 2018, which utilized the endothelin receptor antagonist, showed promise both in renal as well as cardiovascular benefits. And now, currently, we are in the era of expansion era, which is 2025 and beyond. So here we are looking into the one is a landmark trial is a flow trial, which shows the GLP-1 RA in the setting of CKD, and it was showed that it is said to have more renal protection even this CKD stage 3 and 4. And these landmark, the trial which are in the pipeline, this FINE CKD, Arctic, Pacific, EC Kidney, Zenith HP, these are all molecules which are trying the earliest steps. That is, they are trying to inhibit the aldosterone synthase, thereby prevent the, now RASI are looking at the end blockade, but here they are trying to look into the proximal pathways to inhibit the aldosterone synthase, which the results will be, we'll get the results to know how these are going to work. So this would be the gross eras that the therapeutic progression has gone. So this residual risk is, in spite of all these molecules, it appears as if we we have conquered managing the CKD, but still in any landmark trial there is always a vacuum, and we still have a residual risk, like in renal, be it IDNT, Fitligo DKD, whatever, this RAS inhibitor trial, still we have a residual risk which is unaddressed, and that is causing progression of CKD. Similarly, in the landmark SGLT2 inhibitor also, whichever trial they show a benefit when compared to the placebo or the other molecule that is compared, but always there is some residual risk that is left unattended. So this is a slide which shows the percentage of residual risk in various studies like renal, IDNT. So anywhere between 9 to 10 to 40% residual risk always remains even in this 2025 when you are addressing a chronic kidney disease, especially due to diabetes. So what are all the drivers of pathogenesis in diabetic nephropathy? This can be three major drivers. One can be the metabolic disturbances that occurs, which is basically secondary to the poor glycemic control and advanced glycation end products, or it can be due to the hemodynamic factors, which is basically your afferent arterial vasodilatation and efferent vasoconstriction, increasing the glomerular hypertension. And the third component where this mineralocorticoid antagonists are chiefly playing a role is this mitigating this inflammation and fibrosis. So we need to have some agents which are addressing this reactive oxygen species. So this is essentially my talk. Basically, and looking at a molecule which can have some role in mitigating the oxidative stress that the kidney undergoes, which culminates in tissue injury, inflammation, and apoptosis. So there we have this molecule which is N-acetylcysteine and kidney and N-acetylcysteine. So this is basically a direct scavenger of the free radical, and it is an antioxidant. As you all know, this is widely used not only in the kidney in the setting of liver disease. It has been shown that NAC can lower albuminuria and may even postpone the onset of progressive diabetic nephropathy. And in a systematic review and meta-analysis involving 15 trials, NAC has been shown to improve the kidney function, decrease inflammation to a certain extent, and thereby indirectly decreases the cardiovascular events among people with chronic kidney disease. And this is one paper which is published in European Journal of Internal Medicine in the year 2017, which was a retrospective study. The reason here to present is the number of population involved is to the tune of around 1.25 lakhs. And this use of this molecule was associated with the 18% reduction for ESRD. And this is a recent article in 2013. Which showed again, a reduced CKD progression in people who have been using this NSL. However, this is a retrospective study, and the incidence of, they showed that the incidence of hemodialysis was significantly lower in these users with NAC when compared to non-NAC users. And how this molecule essentially works is, it has been shown that this acts at various structures in the kidney. Like if you take the vasculature, this can regulate the blood flow, increase the serum level of nitric oxide, reduce the intrarenal RAS activation. At the level of glomerulus, it scavenges reactive oxygen species, and it acts at the level of the proximal tubule to regulate the sodium transport, and on the level of there is medulla, there is osmoregulation as well as cell volume regulation. So basically this decreases the ischemia reperfusion injury by decreasing the epithelial cell apoptosis and necrosis. So this is what I was explaining. The N-acetylcysteine and taurine nephrosis prevents reactive oxygen species mediated damage to the glomerular filtration barrier. And what are the evidences to see? We have got single center, multi-center, as well as some real world experiences. The first one to come was published in Indian Journal of Nephrology in the year 2008. This was a small study involving 41 patients. They have been added that at that time the standard of therapy was always ACARB. So this molecule was combined with ACARB, and they were able to show in a period of 3 months that the urine ACR reduction was around 45 in the group that have been used this, and it was to the tune of 90 in the group that were not, it was like 90 in the group that has not been given. The second report is from the published in Kidney International, which is a randomized double-blind properly done study, which is a prospective multi-center as well as randomized double-blind control study. And this was done in Pan-India with north, south, west and east. In south it was from the Meenakshi Mission Hospital and Research Center. And here they were able to show that they looked into three parameters. One is the urine albumin creatinine ratio. Overall, UACR declined by 18.6% in the group that used this N-acetylcysteine and taurine. However, the results were more better in the group that is in early stages, that is stage 1 and stage 2, where it was to the tune of 34%, and when the patient has got higher degree of CKD in stage 3 and 4, it was lesser, that is 50%, 20% reduction in macroalbuminuria was noted in the group that was studied. Similarly, the other molecule cystatin was studied, and they showed that cystatin, the reduction in cystatin was to the tune of 20 in the group that used N-acetylcysteine when compared to the group that was put on placebo. And the other parameter that was studied was eGFR. The GFR reduction was, that's the, mean to say the preservation of GFR is better appreciated in early stages of CKD when compared to late stages. So, this adjuvant molecule can be used whenever that you have early stages of CKD, it can be used. To summarize, an 20% overall reduction in UACR was seen in the N-acetylcysteine taurine group compared to placebo, and as I was saying, it was more evident in microalbuminuria than in macroalbuminuria. Overall cystatin C reduction was to the tune of 20%, which is more when compared to the placebo, and N-acetylcysteine plus taurine along with low protein diet helped in preservation of GFR at 6 months of therapy. Then this is a real world evidence to show how this can be used in the setting of proteinuria, and this again is a pan-Indian study with various centers, and here they were able to show that the overall reduction in urine albumin creatinine ratio was 10% after 30 days of therapy, and UACR reduction was to the tune of 20%. As the CKD worsens, the lesser is the result. So, the thing is that if we want to initiate, it is better to have, and the results would be better if it is initiated early. As you can see here, it was 17% in stage 1 CKD and 15% in stage 2, and it dropped to 1.19% in stage CKD 3. So, summary, along with standard treatment, this is what is more important. We are not here to say this is a standard. Along with standard treatment, NAC and taurine can be considered as an adjuvant therapy in patients with microalbuminuria, more so in CKD stages 1 to 3, and the benefit can be significant reduction of microalbuminuria in 3 to 6 months. It's not like you stop with 3 to 6 months. If the patient continues to say, you continue. It's not a therapy like it is restricted to 6 months, and better to go with the BID dosing, and there are studies to show how BED dosing is better. And we have one other molecule which is adding pyridoxamine to this low protein diet, and this evidence comes from this trial which show that adding pyridoxamine to this N-acetylcysteine, the GFR was 8.5 unit higher in the NAC and pyridoxamine group and compared to the control group. So this is a summary of the various studies that I have discussed, the pilot study as well as the real world experience. So now we have few evidences, more indexed as well as retrospective, prospective studies to show how this molecule can be used as an adjuvant therapy to the standard of care that we are already having. So to conclude, we all know the standard pillars of diabetic kidney disease management is RAS inhibitors, SGLT2 inhibitors, NSMRAs as well as GLP-1RA. However, this residual risk that is there can be addressed to a certain extent by using these molecules N-acetylcysteine and taurine, and it is important to use in the early stages of CKD and not, it doesn't probably work in late stages of CKD. Thank you.
Thank you very much, sir. It was nice you took us through the era of evolution of CKD therapy, and thank you for clarifying that this NAC has some specific role in early stages. Thank you very much.
Thank you.
Do we have any question? Yes, sir.
So for all diabetic patients, we have to screen for microalbuminuria and UACR.
Yes, sir.
Am I correct, sir?
Yes, sir. Yes.
But only if I do microalbuminuria only, I'll be totally shaken up, sir, because plain microalbuminuria will not give any kind of information. Maybe due to exercise, maybe due to fever, some infection, and only doing microalbuminuria, it is not going to help the doctor. So you have to do along with it UACR.
Yeah, yes, agreed, sir.
Now question is, sir, you have mentioned UACR, and the molecules which is said to be right now, which is going to give a lot of promise in the next 2 years, was ARBs. Now as in this non-steroidal molecule like phenol has come into vogue, along with empagliflozin, I think so the confidence study has shown much, much more benefit. Along with your acetylcysteine plus taurine, will add to the residual risk also.
Yes, sir.
Will it be okay, sir?
Yeah, that is how we have to take, sir. The standard of care has to be always applied. Any trial involving all these molecules, or also the run-in phase, all include SGLT2. It was not a direct comparison between the molecule and the placebo. So standard of care will still remain the RASI. So added to that, we have to select the kind of patient and add SGLT inhibitor or finrenone or GL1RA.
Sir, I would like to add a comment here, and this is just a suggestion for everyone. I think NAC and taurine combination is widely used and prescribed in India. This is a reality, and many of the nephrologists and even diabetologists, they are using this molecule. So why don't we do some hardcore research and try to find out the final answer that where to place this molecule, because there is no doubt it is used widely. And whenever there is a nephropathy, you will always find a NAC or taurine written in the prescription. But it is not with the globally it is not written. Now we have the standard of care is very clear that you have good glycemic control, control of blood pressure, dyslipidemia you control, add SGLT2 inhibitor, then you add finrenone, and then you add GLP-1. So the treatment line is hierarchy is 1, 2, 3, and control of sugar, blood pressure, and the dyslipidemia. So we need to find this place. I think your studies are interesting, and probably those who are extensive users can contribute to the data as well.
Sir, in the case of non-diabetic kidney disease,
Sir.
patient having IgA nephropathy,
Yeah.
wherein the albumin was now somewhere about 2.6 grams. So when I subject this patient with finrenone, it dropped down to 100, sir. Within 6 months, I was able to get the whole thing reversed back to 100. So that is the beauty of this molecule. And I think so this message should reach all the doctors wherein they can be able to take in a big way to prevent the CKD.
Yes.
So we were talking about CKD, but CKD along with the cardiac problem, it is a double jeopardy to the patient, sir.
Thank you, sir. Thank you very much for the input. Thank you.
Okay. So if there is no other question, but can I ask one question from Dr. G. Vijay Kumar, sir? And the utility of the premix insulin also. Sir, can I have both of you on the stage for the next 5 minutes? So globally, the use of the premix insulin is now being discouraged. And most of the guidelines, they don't find a place for the premix insulin. So what are the best clinical scenarios, considering with the advent of newer insulins, the generation 2 insulins, where do you exactly place 1 or 2, 3 clinical conditions where do you think this, yes, these are the clinical indications where the premix insulin is still going to work?
Majority of the patients end up eating carb-rich food. So if you look at the South Indian way of eating behavior, 70% of our food stuff, all 3 times is carb. So there is a clear role for having a premix insulin, because when we start basal insulin, the progression to the basal plus regimen is further delayed because of various factors. But straight away when we start premix insulin in appropriate patients, probably we are addressing both the fasting and postprandial control straight away, and the HbA1c reduction might be faster. I think Dr. GVK sir uses premix.
Whatever you
sure.
said, okay. Every molecule in practice is useful. Only thing is we need to use the right molecule for the right patient at the right time. That's no doubt about it. Right way. But I mean, why basal insulin is that? Because definitely it's easy to use, easy to initiate, and very simple it is regimen. Now the argument that comes about basal insulin is it cannot control the postprandial. It's not true. It is not true. When you talk about postprandial blood glucose, 40% of the postprandial blood glucose is contributed with hepatic glucose output. It's not only the fasting. If you look into the fasting blood glucose, it is totally because of hepatic glucose output. But 40% is there. So that can, any hepatic glucose output can be reduced with a very small dose of insulin, whether it is endogenous or exogenous. That is number one. And then so that it can be there, only when you want to have that, the disease progression, when basal insulin may not be available, but in our practice we are seeing 5 to 10 years even. But laptop trial, what has been done with glargine is for about 2.5 years, it was able to sustain HbA1c less than 7. That is one part of it. But there are one more situation where practically what we can think about is that when your fasting is not very high, say about 120, 130, but postprandial is 240, 250. This is the case which can happen most of about 30 to 40% of the patients where we can start premixed insulin instead of basal insulin.
I completely agree with you, sir. And one more question which is related to this only, and sir started his talk with a note that now the insulin companies are becoming the GLP-1 companies or the obesity companies. So with the uses of, I think now all of us have wider experience of using both tirzepatide as well as the semaglutide 2.4 milligram, or these doses are available. And we have seen that the doses of the insulin, the reduction in the doses of the insulin is remarkable. Many of these patients, they often go into hypoglycemia, and you very frequently you require reduction in the doses. So here again, placing a premixed insulin can also be sometimes tricky. So I think we need to be aware, and if we are using with the molecules like GLP-1 and the other molecules. Even the others, yes, we have seen that, yes. Most of the time.
So many
No, there is
GM
one.
people, they do better with premixed insulin. They need small dose insulin
Yeah.
for both meal.
Madam, that's what I said. See, even premix is useful, basal insulin is useful.
And
Only thing is you need to age the
and
right
when
patient.
people need
Now
3
we have
times
one.
insulin?
Now we have one more option. Basal insulin with GLP-1 receptor analog, which controls the postprandial blood sugar. It's a very good one. That option is also available.
Many times people find.
Sir, Dr. Vijay Kumar, I have got a question to you, sir. The burden of diabetes in India is 101 million. Pre-diabetes 136 million. So we are in a very bad shape. So what is the role of gliflozins in early diabetes? When I say early diabetes, my HbA1c value is 5.7 to 6.4. There may be, you may say there is no evidence, ADA, ESD, all kinds of things you may talk.
See,
I am talking a practical question where I am coming across every day in and out. Sir, you can talk on the stage or off the stage, it will not be recorded in the...
Off-label use, yes, you can
No,
use.
off-label. Sir, I don't want any evidence-based because, we should generate our own evidence base because we are such a big population, Southeast Asian population, different in all kinds of things. Pre-diabetes is more dangerous than diabetes. If you go through the whole history, it is more dangerous.
Sir, there is evidence for conversion rate to be reduced from pre-diabetes to diabetes if you have metformin and even TZD. It is there. And even with acarbose we have. But unfortunately, there is no indication or no studies done with SGLT inhibitor. Yes, sir, I will agree
if you
with
talk
you.
about the-
See, but you can still use SGLT inhibitor in this stage, provided this person has got also comorbid conditions like obesity, hypertension, and dyslipidemia. Why not we use it?
That's
Because it's an anti-hyperglycemic drug, it doesn't give an hypoglycemia. There's no harm in using it.
That is
I
why
would
I
be
raised
too
this
happy
question,
to do
sir.
that. Yes.
sir, another important drug which we are forgetting is the pioglitazone. So there is a IRIS trial which is on the pioglitazone, and it was done only in pre-diabetic patient only. And so there are multiple drugs which have been tried and tested. And if you talk about the prevention of diabetes, then there is a trial which was done by Dr. Ramachandran group from the Chennai itself, and it is the Indian Diabetes Prevention Study and the IDPP2, and they have used metformin for the prevention of type 2 diabetes. And the metformin is one drug which is officially approved for the use of, even in the uses of the pre-diabetes.
Because all the pre-diabetes are overweight, sir. You take the BMI, you take the hip waist ratio, height waist ratio,
sir.
everything is high.
No, because the information that is available, like, Sundar Mudaliar group from US, what is the reduction rate, sir? 85%. 85%, which is not with metformin, lifestyle changes, nor with acarbose. Pioglitazone is able to bring down by 85%.
One of the fantastic drugs, sir.
Thank you, sir, for your comments. Now we have received cue from Shanmugam, sir, that now we have to wind up this session. Thank you, respected speakers, for your excellent presentations. Thank you.